Dr. Kale Ashish from obtained a diploma in endopelvic surgery, May 2006, in University from Kale, Germany, and also from India, Embryology, from Singapore, fellowship in ART, Cleveland, USA, member of many prestigious society. And well, he is going whether for ART or for endoscopy. Our deep pleasure to have you, sir, with us today. And he will present, it will be endometriosis and enigma treated laparoscopically.
Thank you, Professor Iman, for inviting me, as well as Dr. Mohammed, for having me here in this prestigious gathering. So before wasting too much of time of ours, I will go to my presentation. The presentation, can I able to share my screen? If someone stop this sharing screen, yeah, thank you. Okay, when we're talking about something is related to the endometriosis. The endometriosis is a disease which can be taken from the adolescent to the reproductive age group, and there are the cases where we found out the endometriosis in a perimenopausal age group too. When you're talking about the endometriosis, one should be very much worried about the diagnosis purpose, because sometimes the patient comes down to us in a little bit later stage of endometriosis. She may have the pain during the menstruation or during the intercourse, but diagnosis takes us 7 years. That is the statistical data which tell us. As being the endoscopic surgeon and doing the endoscopy for years together now, I think there are certain cases that one should be looking for the medical line of treatment rather than always a surgical type point of view. Because those who are doing the IVF as well as the endoscopy for this particular disease, it should be taken into account which cases has to be dealt with the endoscopically and which cases has to be dealt with the surgical medical line of treatment. So greetings from India, and there is no disclaimer for my talk. This is our own studies and own videos I had doing it for last so many years. So when you are talking about something related to surgery, the surgery point of view is like whether we wanted to go for it, the patient point of view, whether I really need a surgery, whether I required it, or just is a presumption that surgery will take care of each of my disease. This is a dilemma, and this is the enigma to discuss about. It basically depends upon whether I need a surgical line of a treatment or whether I need a medical line of a treatment. Will depend upon the age of the patient, whether the patient is symptomatic, even if there is an endometrioma, which is 3 centimeter. And having said that, it is a symptomatic, then one should be taking about a surgical line of a treatment. Then one should respect the desire of a fertility and the stage of a disease as well as the duration of the disease. What I mean by it, when you are talking about the stage, if the stage is 4 and it's a frozen pelvis, where you are going to do the operative per se is only going to relieve the symptoms of the patient. But you're thinking on the fertility aspects of it, whether my surgery or surgical step will enhance the fertility outcome, that has to be taken into account. So we'll come down to the basic things of endometrioma, whether the ovarian endometrioma requires the treatment of a surgical excision of a cyst, or whether just is a fulguration of the cyst wall, or whether we do a cystectomy, and really it improves the fertility outcome or not, that has to be talked about. There are so many studies which from 1998 till 2003. There are the weightage. If you weight the two studies, if whether I should go for operative or whether I should go for conservative line of treatment in endometriomas prior to the pregnancy, you can see these are the two groups, and in which there are the publications and papers has been discovered between the two also. So do we need to remove the endometrioma before IVF? You've seen the endometrioma and you thought that endometrioma should be removed or not, because endometrioma surgery before the IVF treatment, we should be thinking of whether it is really going to improve your outcome. What is the oocyte quality? What is the control over hyperstimulations when you're talking about giving a gonadotropins? Whether these gonadotropins, along with the endometrioma, is requirement of the gonadotropins, usually it is on the higher side. Does that endometrioma per se is the person responsible for the fertilization failure or implantation failure? That has to be talked about. The rule out the malignancies, because we never know, this endometrioma may turn into the malignancy of it. So we need to understand the balancing between all these two. And whenever you're doing the and PID and the infection, what precautions you will be doing when you're going for own be the necessity prior to the ART is to have to one should be knowing about restoration of the pelvic anatomy. If it is a grade 1 endometriosis and you are done the excellent surgery, what I mean by the excellent surgery of is like maintaining the anatomical structure. If the uterus is retroverted or if there is a peri-ovarian adhesions, you need to understand that all of us knows that there is a tubo-ovarian angle, and this tubo-ovarian angle is not been properly maintained, you will have the infertility. The risk associated with oocyte contaminations when you're doing the OPUs, and while doing the OPUs, you have the puncture the endometrioma. The size, like there is always an increased possibility of having the infection in those. The location of the seeds blocking the healthy follicles, one has to be looking into it. These are the certain things which is my video where we are just doing the correction surgeries. Here, this is the chocolate material of endometriosis. We diagnosed it by doing ultrasonography. The ovaries and the AMH that plays a role. One should be talking about the when you're talking about fertility enhancing surgeries. What is the age of the patient? What is the AFC? What is the AMH that has to be dealt with? You cannot just do a cystectomy and dropping down your AMH and AFC, which will not be a good issue for treating the patient. Definitely a rectal endometriosis and has to be excised, because there are the reports where the rectal endometriosis, if you are doing the proper job, the spontaneous conceptions are there. But see, whenever this you wanted to do a restoration of the anatomy, this ovarian fossa readhesions and the peritonectomy is the answers towards it. I'll just fast forward a little bit of the video for our understanding. This is the way where we just restore the anatomy, because if you see, the rectum is freed from the posterior surface of the uterus, and the ovarian and the tubo-ovarian angle is been restored. But mind saying that this always not the case. Though you have to be concerned about what I was talking about is the AMH concern regarding her reliability is again the issue. When it is not the reliable that much, because we know after the endometrioma surgery the AMH drops down and it rebacks in 3 months. But what then? What is the specific biomarkers? The specific biomarkers can be AFC. AFC do not organically same. And mind well, when you are doing the cystectomy, there are certain principles to follow. It is a blunt dissection. And when you come at the cortex, don't use a much more of the bipolar coagulation. It is advisable to do a hydrodissection in the proper plane. And if you are in a proper plane, you will not going to have the more excision of the wall. And definitely, you are pathologist. You have to ask the pathologist whether it is only endometriotic cyst, or you can find the antral follicle along with it. Because if I'm just pulling the cyst wall, there may be a possibility that along with the cyst wall, the antral follicles may come up. And this was the take home when you're talking about the endometrioma, whether the ablation or whether the excision. Because mind well, my friends, the endometriosis is a disease of recurrence. Always you cannot assure the patient that I've done a surgery and it is the last surgery. No, the patient will come back to you with the recurrence of the endometrioma. Then what to be done? So these are the certain things, the like art of a surgery. The art of a surgery is like to be in a proper plane. Don't be just do a surgery point of view. You have to think that the fertility aspect of the patient. And when there is a defect is more, you can just think whether the hemostasis is proper or not. You need to understand that if there is a defect is more and that is bleeding, instead of coagulation, you can just do absorbable sutures, and you can and suspend the ovaries. There are the papers that all of us know that you suspend the ovaries to the anterior abdominal wall. the chances of readhesions are less. So these are the certain principles that you have to be taken into account. Then coming down to the what are the our guidelines, all of us knows that, so I'll not go into the details of the guidelines. It's available everywhere. But mind well, if it is less than 3 centimeters, no need to do a surgery unless and otherwise it is a symptomatic patients. If there is a symptomatic patients, it has to get operated, and the better way to operate just to do a prior workup with your AMH. That will be a good things to be done. So how many surgeries you will damage? The accidental removal of the healthy ovarian tissue, and which will cause decrease in AMH, what I was talking about. So it's better to use a minimal electrocoagulations, and per se, you can use a point coagulation. So see well, do a thorough cautery and then come out. The endometrioma and ovarian disease, this I was talking about, more difficult to document the same with the AFC. But if you are having said that, the ovarian reserve, if you wanted to compare between the head to head and your surgical skills, it is better to compare with the AFC rather than the AMH. The stage 4 disease, the coming down to the what the because what we can think of stage 4 disease, and she's having the fertility per se. She is chronic, having the chronic pain. She's having the pain while having the intercourse, and that could be something we call as a DIE. DIE definitely required the surgical experience of a surgeon to deal with. Again, it is a nerve sparing. One should be taking care of the hypogastric nerves and nerve complexes in the parabolic region. The segmental resections as well as the disc excision, there are much more debates about it. But mind well, my friends, if it is more than 2 centimeter, the nodule, it is better to excise rather than the disc excision. The shaving has a beautiful role. When you do a rectal shaving, it causes 80% of the pain relief, and it's the least complications, because when you have a segmental resections, there is a leak and all that complications. Those who are a laparoscopic surgeon in August gathering, they must know, and they are knowing about it. What are the complications of this particular procedure? So this what we had the patient is about, and the basic principles is the sigmoid mobilization. There are the 4 steps. Those who are just doing their endoscopic work, these are the 4 steps one should be following. You have to do go from the virgin area to the adhesive area. You have to go from the sigmoid mobilization. Do first is a mapping of the ureter, because ureter is our good friend, and if your ureter is in our vision, you're less bother about anything is going to get damaged. And then go in the parallel dissection. You dissect parallelly, because ureter has a mesoureter, and mesoureter is a beautiful to dissect about, and you can take care of the ureter in that particular plane. And if you start going dissecting plane by plane, mind well, these are the oozing that is going to happen. Don't worry about the bleeding part, because endometriosis is the part of inflammation. So you can definitely have the bleeding when you are going to dissect it. So don't do a coagulation much. Dissect more and then do a point coagulation. Dissect ureterolysis, then go to the plane of the ovarian fossa, do ovarian fossa adhesiolysis, and then go for your pararectal spaces. The pararectal spaces is a beautiful plane where only the point of a nodule which is going to stick to the uterus. So if you dissect between the 2 pararectal space, what you are going to address is the rectal nodule, which you can definitely take care of. I'll just fast forward my video. If there is a time, I can show, or I can just fast forward it. And this is the where we are just, there is a kinking of the ureter. Take all the disease out. Mind well, if you are leaving the disease behind, this woman will come down to you with the hydroureter again. So it is better that the first surgery should be the complete surgery, and it should be a last surgery for that patient. And what the literature says, the symptomatic woman with the severe endometriosis, repeated IVF implantation failures may benefit from the extensive laparoscopic surgery. So here the laparoscopic surgery plays a role. But mind well that the another thing has to be considered upon. You have to do a stimulation prior to the surgery. Get the eggs retrieved, make the beautiful blastocysts, cryopreserve them, go for the surgery, clear the anatomy, and then do a nice eating. So these are the certain things that I will not go into the details of how the oocyte has been hampered in endometriosis. All of us knows that if you compare the normal woman with the woman we're having the endometriosis, is not only the anatomy that is defective. It's a defect in all over things. So the good ongoing pregnancies, we need to have the two number of M2 oocytes and the healthy composition of the mitochondria in the oocytes. In endometriosis, we know there is a low mitochondrial DNA content of the oocyte, so we're not having the same oocyte quality as that of the normal woman. So what is the take-home things? Let's know the evidences. One should be doing the oocyte freezing. If the patient is young, you can definitely have the younger age patients do offer this particular protocol. Survival rates, where you have to think about the recurrence things and all that thing, the live birth rates, and the age category of these patients. Uh, these are the certain things which were compared the unilateral surgeries, bilateral surgeries of endometrioma, and the no surgery group, where you clearly understood if there is a bilateral disease, the M2 oocytes are going to be have a much more outcome. If the younger the age group, it's better to do the operative rather than the older age group, because we know in the older age group we have the lesser M2 sites. Always they have the lesser AMH and lesser AFCs. So if the patient is of the older age group, it is better to go for a ART procedure first and then the laparoscopy in the later half. So the fertility preservation gives to the patient with the endometriosis valid treatment options to help their reproductive outcome. uh, these are the certain things that's the steroid metabolism and things. To end my talk, I definitely like to quote the think twice and be wise. So when you're thinking twice as a treating physician, as a treating clinician, it is better to think twice about the patient. Every patient is different. Every individual is different. Make the call according to the patients. Thank you, organizations and organizing team for inviting me.
Thank you, Dr. Kale, for a very excellent presentation.